Good day and welcome to this webinar on living with dementia and osteoporosis. What are the challenges and opportunities? My name is Dominique Pierron. I'm the science manager at IOF, and I'm delighted to moderate this webinar. Before introducing the speaker of the day, I just would like to inform you that attendees are automatically muted, and I would like to encourage you to ask your question during the webinar by typing them into the question box of the control panel, and I will voice them to the speaker toward the end of this webinar. Now it's my great pleasure to welcome today Professor Alexandra Papayannou. Dr. Papayannou is professor in the Department of Medicine, Division of Geriatrics at McMaster University in Canada. She is a member of the scientific advisors of osteoporosis and of the IOF, and the founder and executive director of the Gera Center for Aging Research at McMaster University and Hamilton Health Science. Dr. Papayannou is a national and international leader in geriatric medicine research. She is a recipient of many awards, and I will just mention one. She is a 2017 recipient of the prestigious Canadian Geriatric Society Ronald Cap Distinguished Service Award for her outstanding contribution to senior health care in Canada. She has held a number of leadership roles in different societies and organizations. She is a member of the McMaster Institute of Research on Aging Executive Committee, and she has published more than 360 peer-reviewed publications. Thanks again, Professor Papayannou, for having accepted our invitation to present today, and we are listening to your talk.
Thank you so much, Dominique, and thank you to the IOF for this very special opportunity, and thank you to all of you attendees who are joining us this morning or wherever you are in the world. So living with dementia and osteoporosis, what are the challenges and opportunities? And this is an area that there's increasing interest. So my disclosures, I have received grants and research support from Amgen, as well as honoraria from the Ontario College of Family Physicians, the CIHR, our Research Institute, Osteoporosis Canada, and McMaster. So one of our challenges is for clinicians, they'll typically hear this, older adults, and this is a study by Lindsay that was published in 2001. Unfortunately, despite the number of years since its publication, there's still challenges. Older adults think they know what osteoporosis is, but less than a quarter think they could explain it to a friend, and 4 out of 5 don't think they're at risk. And most think it'll be affecting them only much later in life. And so one of the major knowledge issues and attitudinal issues we face when we see individuals with hip fractures or any fractures is they'll say, well, it happened with a fall. So they don't associate it with osteoporosis. Now, dementia is an umbrella term for the loss of memory and other functions such as visual spatial, calculation, executive function, which is the planning of tasks, one of the tasks, social abilities, personality, judgment, and insight. Those are just some of the cognitive changes. It becomes dementia when it affects everyday function. So this is really important. When we're taking our history, we like to ask activities of daily living, such as getting dressed versus instrumental activities of daily living, IADLs, such as banking, cooking, driving, and that'll give us some idea in addition to the cognitive testing. So cognitive testing alone doesn't make the diagnosis. The most common being Alzheimer's disease, followed by Lewy body, vascular, often mixed Alzheimer's and vascular, frontal temporal, and others such as Parkinson's. Mixed dementias is from more than one cause is often quite common. Why is this important? Is that despite a number of New England Journal publications showing that overall the age adjusted incidence is declining, there are a growing number of older adults. So we think dementia has declined due to a number of factors. It may be better education, better vascular risk factor control. However, you will see in this slide that there's going to be a 68% growth between now and 2050. So this is very topical and the costs are enormous. And you can see from the global map that the areas that have lower income and middle income countries will have the biggest impact, biggest impact of dementia. And so those with lower education, lower socioeconomic background are a much higher risk. So how do we put these together? Osteoporosis, the bone, the brain on the other side. So the link between osteoporosis and dementia. 40% of patients with hip fracture have a prior diagnosis of dementia. Why is this important is when we're seeing individuals in the hospital or clinic, your prescribing may be impacted. So patients that you think may be non-adherent, it may be that they have cognitive impairment. And it's not always formally assessed even in hospital. So it's important in those individuals with hip fracture to think to yourself, does this patient have cognitive impairment? Will they be able to adhere to a once weekly medication that is complicated? So depending on what country you're in, your guidelines, you may have other options. We also know that those with dementia have, the study started back in 2010, indicating that there was an increased risk of fractures for those with dementia. And then what they also found is that the bone density is also much lower in those with dementia. Why the overlap? We're not totally certain, but there's some common risk factors such as age, sarcopenia, particularly gait, propensity to fall. They have similar biomarkers, lower vitamin D and K levels. Does dementia impact on the care of individuals with osteoporosis? This is from Dr. Seitz, who did this analysis using the Institute for Clinical Evaluation Science, where they looked at the province of Ontario. And they found that those with a diagnosis of dementia tended not to receive any rehabilitation. And this resulted in a much higher mortality of 43% and long-term care admissions at 63% versus those that were receiving rehabilitation. You can see that their mortality is less and long-term care admissions are less. Now, one thing we do know is that end-stage dementia, the mortality is approximately 40% post-hip fracture at 6 months, so extremely high. But there's quite a spectrum of those with dementia who end up in acute care and hospital. So if somebody is still able to dress themselves, bathe themselves, or even with support, they can often live at home. So we have different streams of rehabilitation, sometimes what we call a slower pace, where individuals with dementia have more the repetitive rehabilitation mode that takes a little longer, sometimes 6 weeks to 2 months, but we still can get those individuals home. So, what risk factors for falls and fractures in older adults with dementia? Are they similar? Is there overlap? This is a very nice paper that was published by Gantz in 2020 in the New England Journal of Medicine. And there's been international falls guidelines just recently published that I encourage people to read. But major risk factors include medications, and we see the polypharmacy when people are on more than 5 drugs. And you can see cognitive impairment has a relative risk of 1.32 for falls, as does depression. Many of the drugs associated with falls are also associated with fractures, and we often will review these in individuals post-hip fractures to see, or hopefully before, are they at risk. Drugs that people can buy over the counter like diamond hydrate, which is Gravol, or another name in different countries, oxybutynin for bladder, Paxil and SSRI, olanzapine, have anticholinergic effects. They've been associated with falls and fractures. What's interesting is the highest risk time is within 30 days of using the drug. So that's a very high time, high risk. So we often see people showing up in hospital after they've taken these medications. Antipsychotics that are sometimes indicated in older adults living with dementia when there's delusional thoughts. Sometimes they're used for behavior management, whether appropriate or inappropriate, can be also associated with a very high risk within the first 30 days. And interestingly, some places and countries will often use them in acute care and putting this individual with a hip fracture at much higher risk, it causes somnolence, extrapyramidal effects, affects the gait, increased postural sway, increased fragility fractures. One thing is what's interesting with individuals with dementia is they have difficulty with dual tasking. And so that affects their gait and increased propensity to fall. Manuel Odessa Monturo, who's a Canadian geriatrician, amongst others internationally, has found that's often one of the early signs. So people, when they start talking and walking, can't do both properly at the same time. And it's sometimes one of the very earliest signs. And that's sometimes why we'll see people with very early cognitive impairment fall when they're trying to carry their laundry, and it's not just balance, is that they can't dual task. Now, in some countries, there is memory clinics or in either primary care and specialist office that see individuals with dementia. This is a study that was published, which is very interesting, found very few, 24% of those who were attending the memory clinic had any recommendations implemented in terms of fracture risk. In this very high risk group, and I can probably attest to this, is most memory clinics don't focus on fracture risk or even sarcopenia or frailty. So this is a gap in our current system as we tend to look at individuals with dementia, manage their memory, their behavior, their safety, but we don't look at the final consequence that often results in long-term care is that hip fracture. It's often the hip fracture in somebody living with dementia that ends up making long-term care a necessity or a nursing home. And is there other ways that we should be thinking about our frail older adults? We know that if somebody has dementia, that we should be thinking about their bones and their osteoporosis and fall risk. But how do we identify those who may be frail in the community and the nursing homes who are at greatest risk. We do have FRACs, but we also need to be able to review with our primary care colleagues some unique risk factors. Now, this is work done by Caitlin MacArthur, who's now an assistant professor at Dalhousie, who looked at using the minimal data set in home care. Now, this data set is done internationally for people who are in home care, receiving help in the home after 3 months. It's also done in long-term care more often. So it's done every 3 months by the nursing staff, and they have a dedicated MDS coordinator. And you can see items that are not in FRACs are the cognitive impairment. There's a relative risk of 1.27. Wandering puts that individual at much higher risk. A fall, the use of the antipsychotics, and you can see fracture is an issue, but they only go back 3 to 6 months, depending if it's home care or long-term care. So the model that's been used internationally for many years for home care and long-term care doesn't include the long history of fractures. The other group that we do a lot of research at McMaster is those in nursing homes. Why is this important? These individuals count for 30% of hip fractures. They've repeatedly said that they do not want to suffer a hip fracture if there's treatment options available. They don't want to be transferred from their home, which is the nursing home, to a hospital. Despite people thinking it's the fall, it's actually very few of the falls actually in long-term care result in the fracture. It's only in 4%. And most residents fall 50%. There's a 50% prevalence of falls at least once a year. What's of major concern is somebody who's fractured their hip that we discharge to nursing home, at least 10% are going to have another new fracture within a year. It's a very high risk group. And I think in those with dementia, especially the severe dementia, we may need to shift our approach. Is somebody with severe dementia who's requiring total care, whether they're living at home or a nursing home or assisted living, they may need to be deemed palliative if they're not doing well post-hip fracture. Now, again, there's a spectrum of those living with dementia. In our long-term care group, we developed a tool called the FRS based on the minimal data set. So this set of data is assessed actually both in Canada and the US. They have a different version, but it's really an international model. You can see the falls, 33%, 10% have a past fracture, and that's only within the past 6 months. But one of the things that's different than FRACs is that, again, dementia plays a major role, and walking independently and wandering. So those individuals in nursing home who are still moving, who are wandering, they're very high risk, and we need to think about treatment. And this is what the FRS that's available internationally looks like. It really shows that those over 4, you can see that their risk of a hip fracture within a year, you go from 3 to over 10% within a year. Very high risk group that we need to consider and assess. Does a diagnosis of dementia impact osteoporosis treatment? This was a retrospective study published in 2017 using Medicare database in women over 65 who were hospitalized or were seen to emerge for a prior fracture. A dementia diagnosis was associated with a 7.6 lower likelihood of osteoporosis. despite that high treatment, despite that high risk of a hip fracture. And so numbers as low as only 5% of those living with dementia are assessed and treated for osteoporosis. This is a group that we're thinking may not benefit from treatment. From time of diagnosis to death can be quite considerably. It used to be 10 years. It has increased with the better care. Interestingly, in the Horizon study, dementias and RCTs of osteoporosis drugs, there was no, the drugs still work. Zoledronic acid reduced hip fractures in those with cognitive impairments, similar to the other older adults. It didn't reduce the mortality rate in the cognitively impaired, but again, that subset was small and we didn't have great cognitive markers. So these drugs do work from this one study. There was a study by Chang in 2014 that also was very interesting. It shows a signal that those receiving bisphosphonates may have a lower risk of dementia compared to those not receiving any treatment. Maybe the impact on the mevalonic pathway, we're not sure. We also saw this with HRT. Now again, with observational trials, there's confounders, and we certainly haven't in the RCTs seen that estrogen reduces dementia. So this is a signal, an interesting signal. So what is the relationship between osteoporosis and dementia? There's a major hypothesis there's similar risk factors amongst both the diseases. There's a question of ApoE4 binding to amyloid, and this is a question, is this a factor? Having said that, many studies have controlled for the ApoE4 and have not found that of significance. There's also interesting questions around immune system, genetic approaches. We know that exercise, particularly with mild cognitive impairment, may change the course of the disease, may infect inflammatory markers, the same we've seen early with bone. So there is a number of overlapping hypotheses amongst the bone and dementia. So what is the association between cognitive decline, bone loss, and fracture risk? Now, this was a study from the SOFT group, the study of osteoporosis and fractures, in 2003. And so this area, there's been interest in this area, I would say, since 2000, if not a bit earlier. There's been signals here. Over 4,000 women over the age of 70 they measured their BMD and a modified mini mental standardized test at 6 years and 3 years. And they defined cognitive decline as 3 points or more. They had some genetic testing. What they found is women with more rapid bone loss were more likely to have cognitive decline or dementia. And they controlled for differences in functional status, estrogen use, ApoE4. And so it wasn't quite clear why the bone loss predicted the cognitive decline. And it was in over a 4-year follow-up. This is a German study that was done in primary care. It's over 60,000 individuals. And they did propensity matching on age, sex, their comorbidities and co-therapies, drugs that may affect or prevent dementia, antihypertensives, lipid lowering. And 20% of the women with osteoporosis versus 16.4% of the controls were diagnosed with dementia. And you can see that the cumulative incidence of dementia in women with or without osteoporosis, that those with osteoporosis seem to have a higher risk. This is a Canadian study from our CAMOS group that showed cognitive decline. This was to really look at further, looking at is cognitive decline and osteoporosis, what happens first? Is it a bidirectional relationship? There's a number of studies actually that have found low bone density or rapid bone loss were associated with postmenopausal cognitive decline. The studies are stronger in women than men. And so they looked at, in a cohort of over 10,000 women and men across Canada, followed for over 15 years. They looked to see what the cognitive decline and bone loss was at 5 and 10 years. Oops. And in terms of the methodology, they had over 1,700 women and 620 men that were in this cohort. And they looked at the cognitive decline using a mixed effects model and adjusted for a number of risk factors. And they looked at those with MMSE loss of greater than 3 points versus those less than 3 points. So there were, even after adjustment of the multivariables, there was a significant positive association between cognitive decline and bone loss and fracture risk. So those with cognitive decline had an increased fracture risk. So that is becoming a strong message from the research literature. This was a healthy, this sample was tended to be, as with all population-based cohorts, tend to be a healthier cohort. 95% had normal cognition at baseline. Approximately 13% had a significant cognitive decline, but there were not enough men to look at the evidence in terms of does it impact men as well. So from that study, we do know that there seems to be also a rapid bone loss, fracture risk, and cognitive decline. Again, it may be bidirectional. And most recently, a very interesting study was presented by Larry et al. At ASBMR this year, and it looked at some of the European cohorts if BMD loss is associated with incidence of dementia in cognitively intact adults. They looked at the Framingham study, the Rotterdam study, the Memory and Aging Project, and they looked at bone density at baseline and annualized percentage decline, and they adjusted for covariates. So they found that bone loss was significantly associated with incident dementia in the Framingham study, and there may have been other reasons. There was only limited information on the poster to explain why the other cohorts we didn't see the same change. So this is a slide from Paul Mitchell, which really, I think, is very, really summarizes nicely what are issues. We know that those living with dementia have a much higher rate of hip fracture. Our patients with osteoporosis who seem to have the rapid bone loss may be at higher risk for dementia later on. More research is needed in this area, and more research is needed in terms of the hypothesis. What is the possible mechanism? But certainly we need to think about the patient rather than in silos, the fracture liaison services, looking at these very high-risk individuals that are typically lost to follow-up. Our memory clinics, which tend to focus on the factors of optimizing dementia risk factors and dementia supports. Our falls services, which tend to focus on falls risk factors. And our orthogeriatric services, which tend to integrate things, but not always. How do we work together with our collaborative groups and our subspecialties in primary care to optimize and reduce the risk in this very high risk group? And as mentioned, we do know that we can support individuals with dementia quite well in the community with their families, both formal and informal caregivers. But it's often the hip fracture that and the associated delirium or the confusion that we see operatively that causes further decline in institutionalization. I believe that we can change that trajectory, and I think this is an important group that we need to focus and address. So what do and how to make this work in your country and your setting? So World Osteoporosis Day is coming up, October the 20th. Step up for bone health. Follow IOF on social media and order your posters for your clinic. Step up bone health. Our vision is a world without fragility, fractures, in which healthy mobility is a reality for all. Join us in this very important call to action around the world.
Thank you very much, Professor Papagiannou, for this very comprehensive presentation. Maybe you can let the slide forward on so people can see it during the Q&A session.
Is it on right
now? Now it's not on. We have, I think, you at the end of your slide deck, if you can come back 2 slides or what? Yeah. You can come back one extra. Yeah, we can stay on this one for our audience. I'm sure that your talk first was greatly appreciated by our audience. And first, maybe I would like to move on to questions, specifically, related to your talk on bone and dementia. And maybe while people are starting to type their question, I really encourage them to type their question now in the chat, in the question box. Maybe I will start with the first question is, are there any special consideration when treating patients with dementia for osteoporosis? Because you have a huge experience.
Right. Thank you, Dominique. I think that there is, if somebody is going home or lives at home alone, living with dementia or mild cognitive impairment, a once-weekly bisphosphonate may be challenging. Taking it with a full glass of water, waiting half an hour to an hour before eating, sitting upright. They often, in their blister packs or medication adherence dosing, we often will recommend that they have some kind of medication aid. This individual may be better suited to a subcutaneous medication like denosumab or an intravenous drug like zoledronic acid because of the issues of medication adherence. So really, it's even more of an issue, medication adherence, in those living with cognitive impairment. The other important component about medications in somebody with dementia is when people start having more moderate to severe disease, and many of these individuals still live at home, they may put their pills in their mouth, they may pocket, what we call pocket them, and they don't swallow, leading to erosions in the mouth or esophagitis. So again, this group, over 40% have some swallowing impairment as the disease progresses. So very important to think about alternatives.
Thank you. There is a question from Dr. Taylor. She's asking if the inter-RAI fracture risk score can be used outside of Canada.
Yes, it can be used internationally, and we're happy if you want to connect with us. We can. It's available in long-term care. It's been accepted by Inter-RAI, which is the group that uses this internationally. We have a paper version if you don't have access to the computer program in your setting.
Thank you. There is another question. What strategies do you suggest to address the care gap for those living with dementia?
I think this is where the strategies is. I really think that the organizations like the IOF and collaboration with the Alzheimer's societies internationally need to partner to make this a campaign. This is really a quality of life issue. It really, if somebody has living with dementia, cannot ambulate, can't mobilize, their behavior often becomes much worse. They can't express their pain when they get a vertebral fracture. So they'll often become agitated instead of saying, I've got back pain. I think this is a very pressing problem that we really need to collaborate across the silos. So our fracture liaison teams need to think about how do we work better with the geriatric services, how do we work better with primary care, and how do we work better with those living with dementia.
Thank you. There is another question about DKK1, like the DCOP protein and Alzheimer, because DCOPS, I think, was a candidate, a candidate molecule which could link osteoporosis and Alzheimer's disease. I think there was some literature a few years ago. Have you any update on this potential candidate?
And I think that that's really, that's a very good question. I think genetics, as the international collaborations look at the genetic markers, this is really a pressing need. And to look at alternatives for, markers and genetics that may lead to different therapeutics. But thank you for bringing that up. That's a very important international scope and these multinational collaboratives.
There is one question popping suddenly, like from Dr. Hartoko. He's asking if there are any evidence that the treatment of osteoporosis can improve the quality of life of patients with dementia.
So that's a very good question about, does treatment improve quality of life of those with dementia? Unfortunately, a lot of our osteoporosis trials, the randomized controlled trials, have not included quality of life as an outcome. We do know from a major study published in JAMA that even those in long-term care who were walking with a walker, when they fracture, some of them, a third of them, cannot not even roll independently in bed. after the fracture. And so I think that there isn't direct evidence, but not being able to move in your own bed must have a major impact on quality of life, even if you're living in long-term care. So unfortunately, our trials, it's a very quick question, should be including quality of life as we go forward. We do know that spine fractures in those living with dementia, especially those who are the 85 plus, their fractures are more severe, they become kyphotic, the early satiety, weight loss that we see must impact on quality of life. So again, I think going forward as we design trials, quality of life is definitely included. When we've consulted with families and residents who live in long-term care or nursing homes, their main concern around osteoporosis is they don't want to suffer the pain of hip fractures, nor do they want to be transferred to a hospital after having a hip fracture. Their goal is to remain able to walk in their long-term care.
Thank you. There is another question from Dr. Gibart. Is asking, what do you think about imaging participants in the care home instead of taking them outside to the hospital, using alternative imaging methods such as X-ray or ultrasound?
So that's a very good question. Should we be transferring people out of long-term care for bone density? In the FRS that we've developed, it does not include bone density. Bone density in FRAX would put most people over 90% at 95% at high risk for fracture. When we validated it, it's more like 40%. So using a radiograph, a lateral radiograph of the chest will often pick up those spine fractures. You don't really need even ultrasound if you have the FRS, if you're able to use that. The caveat with the fracture risk scale is vertebral fractures are often underreported and not captured in a lot of the databases that we use to develop the scale. So that's a very good point, is the radiograph in long-term care is an easy way to identify those at fracture risk who have had spine fractures.
Thank you. There is another question more on nutrition. Like, are there any data on calcium and or vitamin D supplementation? Like, do they have a positive effect on dementia? We know that, it's positive for osteoporosis, but what about the effect in dementia? Has it been studied or not?
Yeah, no RCTs to date.
Okay, thank you. And I think, I think we are running out of questions. So I really would like to thank you again, Professor Papayannou. I'd just like to take this opportunity once again to remind everybody that this Thursday, October 20th, is World Osteoporosis Day. And we invite all of you to take a look at our new campaign resources. And we hope that many of you will be celebrating the day with outreach to your patients and to the general public. And this being said, I would like to thank you all participants in this webinar. I hope you enjoyed the session. We will be posting the recording of the webinar on the IWF website, and you will receive your certificate of attendance and the link to the recording by email tomorrow. You will be prompted to fill in a survey immediately after this webinar, and we would appreciate your input and comments. And I would like to thank you again, Professor Papayannou, for your outstanding talk, and goodbye to everyone. Thank you.
Thank you, everybody. Have a great day.